Welcome to Beyond. We got some amazing guests here today, and it's a really poignant topic of our times, talking about testing for COVID-19. And we know that President Trump really touts the number of tests we've run as a country as compared to other countries, but we know it's woefully inadequate at this juncture. The U.S. government is working with private companies to make available millions of coronavirus tests with quick results within a few months, according to National Institutes of Health Director Francis Collins. He said this to Congress on Thursday. Quote, "I must tell you, senators, this is a stretch goal that goes beyond what most experts think will be possible," he said. Quote, "I have encountered some stunned expressions when describing these goals and this timetable to knowledgeable individuals. The scientific and logistical challenges are daunting. Some public health experts have said widespread COVID-19 testing will be necessary to safely loosen restrictions brought on by the pandemic. In its three-phase plan for opening up America, the White House task force recommended states test at least 2% of their populations before allowing some non-essential businesses to resume." I'd like to introduce the audience to John Powers and John Spinoza, who are working with an organization, Rule Out COVID-19, on a study that's being coordinated by Myriad Genomics to radically increase the number of COVID-19 tests being run. Gentlemen, welcome.
Hey, Ben.
Good afternoon.
Yeah, it's great to have you guys on. So as I discussed on the top, the White House is really pushing for testing. I know that it's a badge of honor for President Trump. But the question that really remains is, why has it been so difficult to scale up and bring wider spread testing to the masses?
John, you want to take that first, and now?
Sure. Well, there's two aspects to the test. That you want to make sure that the test is reproducible and safe, and that the conclusions are safe for the patients and such. And so in a typical environment, we have a regulatory environment and the FDA that tries to assure this. And then manufacturers tend to incorporate the complexity of the test into a unit of work that the trade of it becomes logical. I paid this company to make a test that's incorporated by this plastic device with all the aliquots, and it subsumes all the aspects of it. The problem that happens now is that we're in a pandemic where the need for something specialized far outstripped our ability to get to it. And the way you address it is you have to go back to primary ways that a test is first developed and such. And with Rule Out, that's kind of where we got to. How can we do it safely, and how can we scale it using equipment and tools that we have that exist in the research
John,
community.
we'll get to that because I think it's important. Yeah. We'll develop the Rule Out, but right now we're in a rule in sort of paradigm. So let's talk about the current testing so the audience can get an appreciation for what's going on. For current testing, what are the big delays being driven by? I mean, what delays the results that we're trying to get?
So building on what John was talking about with delays of getting tested, when you look at it, like you said, they're doing Rule In right now. So they're looking at the copies of the virus. They look at any regular test in a normal environment. And what that does is it gets people working with a clean environment, which a lot of people look at as more of an FDA restriction, and what they can do. And you're seeing all sorts of emergency use applications. You're seeing all sorts of trying to go around. And what we're saying is, hey, with existing equipment, just changing the methodology and changing the way you look at this as trying to decide who has it, you can do a much faster test, and you can do the PCR, which is the most consistent and recommended. You run what we call an offline test, and we'll get in more detail of what the difference is. But we know you can easily do 20-fold what they're currently doing on every machine out there, every qPCR machine.
Well, that's an order of magnitude difference. But I also read where on some of the reports that COVID-19 infections are not being detected in as many as 30% of tested asymptomatic cases, i.e. that many no infection inclusions are incorrect. Why are the results so off with the current testing?
The problem is you don't have a consistent test across the board. And when you look at all the numbers reported in the news, it's hard to tell what they're actually, what's their denominator? What are they basing this against percentage-wise? And that's why when we looked at it, and John can go on this from the pathologist standpoint, we looked at qPCR because we know it's reliable, and we know you actually get a you get a count of the copies of the virus within that sample. So if you've got a good sample, and what you need to do is you have to set a threshold. We have to have at least 10 copies of the virus. And it can be thousands, but you want to make sure there's a threshold. John, you want to add to that?
So there's additional parameters, is that there's not only the assay itself, but there's how you acquire the sample for the assay. And so we're working towards a best practice of how you acquire those samples in nasal pharyngeal and oral pharyngeal swabs and wet swab, and how, it's daunting for a patient to have this large probe put into their nostril 6 or 7 centimeters. They feel like it's going into their brain. And that can be daunting. So if that's not done well, everything downstream of it can be variable. I think there's approaches that are improving that, but that pre-analytical variable, the way you compensate for that is actually do more frequent testing. And we haven't done that. And there's lots of tests that when they work, they can be very specific, but getting the right sample requires effort. And one of the ways you compensate for that is if I think you have it and I got a negative result, instead of just using that result, I retest.
Right.
If I thought you have a heart attack and your enzymes weren't high enough, I'm going to retest to see if that's still the case or not.
So it seems also that these tests can be impacted by user error. So if I'm swabbing the nose and I'm not doing the right technique, I'm probably going to get bad data. Is that an oversimplification, or is it real?
No, I think that's real. We do it the best we can, and you get better at it with experience. But some of that data that came out was fairly early on when we're learning it, and someone is, we're all worried about and doing this. Am I going to get infected? I have these new personal protective equipment around me that you typically weren't using. I have a long list of people behind me that are stacked up, and I think that makes us a little bit less consistent in how we do it. And it's no fault of the people or whatnot. It's just inherent to the process. And so you have to work on ways of overcoming that. Are there alternate approaches? Are there best practices? New Haven, Yale came up and showed that self-swabbing actually is as effective or more effective than having a healthcare worker do it. And part of that is probably that people are more comfortable with their level and having it witnessed and such. So I think it's not necessarily a reflection that the test is bad. I think it's a reflection of the complexity of the whole process and getting there. So
yeah, and it seems to me when you have a pandemic, you're going to be caught flat-footed. There's no way you prepare for the scale, enormity of the challenge and what we're experiencing. But John Powers, it would seem that there's an advantage between urban centers versus rural areas, right? In urban centers, we put a lot more money and resources to nip in the bud some of those hot spots, but certainly rural areas aren't benign to it. They're certainly dealing with it. And so how do you, when you think about the current test and what's facing healthcare decisions in the rural area, how do we bring COVID testing to the rural area where they don't really have a lot of help? They don't have the resources, the infrastructure to support such testing.
And it's interesting because when you look at it, you look at the numbers and everybody says, well, you're safer in the rural area because you've got more distancing. And it's the same virus. It just doesn't show up as quickly because it doesn't spread as fast. And that's why when we looked at this, we didn't look at this and say, hey, we need a new method. We said, let's look at what's out there. Let's see, the first thing it did is they sequenced the virus. So we know that sequencing is correct. We know exactly what we're looking for. So we looked at the qPCR machines and we said, how do we get the most out of these machines? And the beauty is there's thousands of these already out in research areas, hospitals, universities. So with what we're proposing, and if you're in a rural area, you definitely have a qPCR within, probably within 100 miles. And we know that with the recommended techniques we're we put out there, you can do 7,500 a day on one machine. And you can expand that once you get experience because you cut out the redundancy, which are the replicants. But that's how they cover the rural area very quickly and very easily. You can go up there and there's machines that exist.
So, clearly a widely deployed, robust screening capability that is highly reliable and identify negative cases is certainly needed right now. Higher volume testing would help to identify still asymptomatic individuals who might be already infected for follow-up and testing and perhaps earlier isolation. We know that the current testing paradigm is inadequate to meet the population needs. So let's focus on your solution, which is rule out COVID-19 testing. And how does this differ from conventional testing, so-called, I'm sorry, ruled in, right? Yeah, so-called ruled in.
Well, I'll take that, John, if you don't mind. The rule in and the original tests want to make sure that you have the disease. And so the original test, as it was outlined, had 3 areas of the virus that they were looking at. And to rule it in, they wanted all 3 areas of that positive. And then they did it looking at a viral load type sequence that they could see the presence of the virus load. What you do is, if you're ruling out, what you're willing to accept is that I'm willing to accept a small number of false positives so that my negative result has a lot of power. Because again, this is trying to look at people who are asymptomatic or pre-symptomatic and such. So you want to, it's at population levels. So you want to be very sensitive that a negative result is as true negative as you can get, because you can always follow up with the positives. And so what our test does is just say, well, if we have all 3 of those areas positive, that's great. But even one of them positive, treat that as a positive. And doing that simple change means that you can put the PCR reaction, you can put all 3 areas in a single well, in a single reaction well, instead of 4 different wells, a control and 3 for the virus. And you can put those all in a single, you can put the viral ones all in a single well. So all of a sudden your capacity has doubled, because you don't have to use up as many reaction chambers. And the risk that you have is that you might have someone be false positive, but that's okay, because we know what to do with the false positive. Is we can do a confirmatory test, or we can isolate them and retest them and do things. And the false negative can go on. So.
Right, and I noticed in reading some of the information that you guys are taking a 2-phase approach to building test capacity. What does this exactly look like?
The first phase would be consolidating the test into wells like that. The second phase could be where you can actually combine the control using a different detector molecule, so that the whole thing can be done in a single well, and it can be done with a single pipetting step. And each of those increases the capacity of the instrument. There's actually kind of a subtle third thing, that instead of doing real-time PCR, you do endpoint PCR. So you can have the instrument that reads the reactions can be separate from the actual PCR cycling. And so, because you're just wanting to see if I have a signal or not. And so because of that, you can maximize the use of the detector instrument, and you can have multiple of these going at a time. And all of those changes increase the throughput of what you can do.
And Ben, when
John?
you look at that second step, what John's talking about is you can take a large number of samples and run 8 thermocyclers at the same time. Because typically when you run the PCR test, you're running it's an hour test. So if you're running single samples per well, the CDC and the WHO, they're getting between 12 and 16 samples an hour. So if we're doing it in a single well, we're gonna get, worst case, we're gonna get 48 samples per hour. But if we do it offline on a thermocycler, and then combine them on the PCR machine to do just the end read, which will give us the bioluminescence to show, hey, they're above this threshold. Then we can do 384 an hour.
Mm.
And that's using replicates as well. So that's doing copies of it at the same time.
Right.
So if you get, when you've done this for months and you know, it's kind of like redundancy in electronics. If you're like, hey, at some point you don't need the redundancy because you've got such good reliability,
Mm-hmm.
you can skip that. And that's when you can look at literally in an 8-hour day, getting 15,000 samples run in a single day on a single machine. And that's
1,500.
Yeah. Sorry about that.
1,500. So let's talk about how would this test be practically implemented? So if you're talking to the President of the United States or his task force, in other words, what is the facility staffing and oversight that is required to implement your approach to testing? What does that look like?
It looks like the instruments are relatively small and they're portable, so they can be placed in a site. And the question is, what kind of site do you want? You could have everything from what looks like a pop-up site with a temporary structure to an area of a building that's unused. Because of how the samples are acquired, you inactivate the virus very quickly, and so you can do most of it without having a hood. And so what the rule-out site has is it has a sample outline of the size of the area that you need and what kind of outlets you have and kind of the layout. And then the instrumentation themselves, that's where it becomes an incentive for industry and researchers to contribute their instrumentation to this. There's lots of idle instruments right now from the because of work from home and the shutdown and such. So
John, for the audience's edification, describe what is the instrument that's sitting by idly that's readily available.
There's three mainly. There's a small desktop centrifuge that can be used to remove debris or at least eliminate it. There's pipetters that aren't being used, which are small handheld things. A thermocycler is about the footprint of a
big shoebox.
iPod.
It's a big shoebox.
Yeah, and then the qPCR instrument is
it's a mini fridge.
About
it's a 2 square foot mini fridge. It's a mini fridge.
Yeah.
And it weighs about 75 pounds. It's about the same weight and size as a mini fridge.
So those are so portable that you can actually take them to a site and hook them up and get them recalibrated quite quickly. And right now they're sitting around doing nothing. So if you looked at every qPCR instrument, I right now live in Carpinteria, which has UC Santa Barbara and a couple research institutes. And I would say conservatively, there's probably 10 qPCR instruments in this area that are just gathering dust right now.
Right. Let me back up and take a step back. One of the key questions I failed to ask was, what does it look like to collect a sample from a patient? Describe that process that you're running through this instrumentation.
Well, you have a glorified Q-tip. It doesn't have cotton on it, but it has a kind of a roughened edge on it with about a 7 or 8 centimeter long plastic extension on it, and you put that up into the nose to get the very top back part of your sinus. Alternatively, there's some that you open your mouth and you get the very back part of your throat. And then the tip that you use to kind of roughen it's called the mucosa, the lining of that area, and the sample the mucosa, then goes into a fluid. And the fluid lyses or disrupts all the cells there and releases the DNA and RNA and keeps those from being degraded. And then after 10 to 15 minutes of that, the swab comes out and you have this fluid, and that fluid is what you sample. And then that goes on and becomes the basis of the reactions.
So when
And
a patient comes up, do they need to
the
have
rule out approach.
Sure. So when a patient comes up, do they
Yeah,
need to
go
be
on,
wearing
I'm sorry.
PPEs, or when they present to these labs, they could just come as they are? They get the swab done, and will the results come back while they're there, or do they have to wait a couple days?
No, they'd wait. I mean, they could get it that day if it runs. And the way we looked at this, I'll let John, go on after I explain it, but
Yeah.
just the way John described it, we envisioned that you'd have an accessioning area where patients could come in, especially if you set up a temporary facility, much like a bank teller. They take the sample, they pass it through the glass, and it's the lab's right there connected because you don't need a lot of space for this lab to set up. You put the swab into the tube, you cut it off, you lysis the swab so you can get the sample out, and you can then get those on the machine. Hopefully you're doing this real time, and the accessioning actually could wind up taking up more time than the actual setup for the test.
Mm.
But then you run the test itself takes anywhere from an hour to an hour and a half, depending on your setup and prep. And then you guys will get your results and verify your results. So you could easily get the results same day, but it's a nice, you could literally have a nice assembly line and be doing this on site where the patients are coming in and out. John, you want to add to that?
Yeah, I think that's it. You can, the workflow is very quickly. This is the advantage of having the relatively small equipment that can be done at the site. If and because we differentiate the amplification of the signal from the reading of the signal, you could also have the instrument that does the reading be on a mobile site, and you could be doing the reactions while a sprinter van or a blood bank van or something of that size goes between sites, does all the readings, and then goes to the next one. So it's
Right.
really geared up for distributed things. And the patients themselves, because of that, the patients themselves can just do a witness sampling. You could have it like in this teller kiosk, you could have, here's how you do it. They could be in their car, if you want them in the car, in a small booth, and do it, put it in the sample goes across the plexiglass. They move on, you can clean the plexiglass. And we think that you can speedline this. Remember, the complexity is we're doing a very focused test for a very focused result. And that getting to remove all those optional things that a full service lab would have to do makes it very quick. And you emphasize that.
Right. So what you're describing is really intriguing. So what's the staffing requirement per location and the oversight required to make it, operate efficiently?
Well, the way we looked at it initially is we looked at doing points of service, which is why we're working with local hospitals for the demo, because we extend their CLIA license, which is the oversight piece of it. Mm-hmm. And then we set it up and we set the lab up. There's one basically what you call a CLS, so a clinical lab specialist, to run the machines. They can process everything on a single machine fairly easily by themselves. And you typically want to have someone else doing the accessioning so that CLS isn't occupied. And that's really just collecting the samples. And they can either put them into the tubes, or the CLS can put them in the tubes. But it's a very simple process. There's some automation you can add to it, but there's really not a lot of need to do automation up front. But when you get to the mobile aspect that John's talking about, that's where automation would help a lot, because you're moving the machine from site to site.
Right.
But the oversight really becomes you expand the CLIA license from that center, and John, being the pathologist, can get more into the piece of it.
Yeah, and then the pathologist, as a licensed medical person, can oversee the general approach to it. We have it built out that you still have licensed people, and then you have subspecialists, and so we think it can be done with as few as 3 people. It might be a little bit more than that if you want to increase the throughput of people being sampled. But
so what could 3 people? What would be the throughput of 3 people in a day? If I had, 500 patients, could 3 people handle those 500 patients, or what's the scale we're talking about?
We think we think 3 people could easily do 500 samples in an 8 to 10 hour day. And we think that's actually fairly conservative, and it would be possible to actually go beyond that fairly quickly.
So what's
And
cool
so
about
you
this
could,
concept, you
yeah,
got portable
yeah,
labs that could be set up at like Edwards Life Sciences or a lot of main companies
yep,
or nursing homes. They're portable, they're flexible,
yep.
and you could bring the testing to these sites pretty rapidly.
Yes, that's the whole thing. You could set it up. You could validate the process itself can be validated by the mothership lab. You could set it up, show that the instrumentation is working, and then go on. So you could actually follow hotspots. Instead of having to transport things, you bring the testing to the system where it's close, and you have turnaround times that are meaningful for the care of patients, and especially in this public health setting where you want to be able to track and trace. If you can't get results back for 48 to 72 hours, you're constantly behind the 8 ball. And I think getting things in sub 24-hour segments means that if you ask someone to isolate, you're not asking them to isolate for 3 days or 4 days while you wait, and you can get an answer, make a decision, and go forward.
And that's really the beauty of this is it's the most cost efficient too, because these machines are out there, they're sitting idle, the people are out there, so the labs have a trained personnel. Your skill level on the lab is to be able to pipette and then know what accommodations you're using in terms of the kits. So it's very easy to implement, and it's very cost effective because you're not going out and buying new equipment or doing training on something different.
John, let's talk about that. That's a good point. It leads me to the next question. What is the funding required to operate this testing? Because nothing's cost neutral. Even though there's equipment there, there's going to be payroll. There's going to be some costs associated with having a person there running these tests. So what kind of funding do you think would be necessary if a company wants to bring in this testing, or a hospital? What would that cost those entities or those organizations to set up and run?
Well, I'm actually in the process of filling out a grant request, and it's interesting because it's not. I'm doing it through a charity because it's not a one company that provides this or is providing equipment. But if you look at a PCR device, the qPCR, the one that we've got from Thermo Fisher, is about 90 grand list price for that piece. When you look at the thermocyclers, they're about $3,000 list price. And we're assuming most of that exists. So we're not looking at that as a cost that you got to go acquire. But if you were to get it new, that's what you pay. Pipettes, you look at, the collection tubes are scarce right now, but those are going to be the same regardless. So I won't put those in the equation. The pipettes are 2 cents, basically 2 cents for a vial, not the pipette, the tip. And then you look at a full, one FTE, whether that's a CLS or whether it's an existing lab tech. You look at a full-time person, roughly at about loaded cost of 100 and 120K a year. But once again, we think there's going to be a temporary need for staffing, and then most of these labs will have someone that can do this already, either working in their pathology lab, or someone that'll come that's out of work where the machines are idle. Like you mentioned, Edwards or Thermo Fisher, one of the large life science companies. Mm-hmm. There's plenty of people out there that can do this on a temporary basis because the training for a existing lab person would be very quick. So I think your total all in per site, if you bought everything new, is still under 200K.
Oh, not bad. Hey, so John Spinoza, question for you.
Yeah.
Sort of touched on this, but what is the accuracy or sensitivity specificity of your proposed test for rule out?
Well, we're doing those tests now, but this is essentially the test is the essence of the test that was set up in South Korea and came from the WHO. And that the sensitivity is down to, I have to look at the most recent, down to under 10 copies in the sample,
right?
Which is quite small, and the specificity, most of the false negatives are actually in the sample acquisition. The specificity is quite high in the 98% range or higher. So
no, and I just looked at the data on Saturday. It's 10%. It's 10 copies. So
10 copies. Yeah.
And when you look
And
at some of the other tests, Ben, they got to be, there's literally tests that require 10,000 copies or 1,000 copies, large numbers, copies of the virus to detect it. But like John mentioned, I looked at the test results on Saturday and we're detecting it at 10 copies.
Do you guys have a publication you're working on, or is there published data on this approach?
there's the original published data, which is our white paper on the site has reference to the South Korean one that's done. Like I said, we're not trying to reinvent the wheel. What we're trying to say is what's out there that works. How do you scale it? And the scaling isn't coming up with a new way to do it per se. The scaling is what's the workflow that makes sense when you're distributing the tests, and how do we distribute that in the environment that we have in the US, and how do we get sites that, to sites that need it? And that's where that's really where rollout has, I think, enabled a lot of work, because a lot of those small things that prevent you from starting I have to write policies and procedures. I have to know what the IT system looks like. I have to know how to validate it. What are my considerations on instrumentation that I need? That's all on the website and such. So,
yeah.
So you already have a clearly defined roadmap. You're not trying to.
Yeah, so
we have.
Yeah.
No, exactly.
Yeah. And what John says, the SOPs and all the information you need to actually set this up exists today. And we don't have published data we don't have our published data, but we have our data, and we'll share our data with anyone. But there's really not a need to go through the publishing of it. We can share it, and it's real straightforward. And we can show you that, 10 copies, we can detect to 10 copies, and we can show you results.
Well, specificity of 98% with 10 copies is very impressive. So if this thing blows up across the country, are the supplies needed to run these tests readily available? That means the swabs for the nose. Are they already, in other words, we had a big run on ventilators, right? So we had to create and crank out a bunch of ventilators. So if this thing takes off and blows up, do we have the necessary supplies to run these tests?
The answer is, well, the swabs to obtain samples is how would I put it? That's kind of a pain point for everyone. And that manufacturing is ramping up. So I think that becomes, in a way, orthogonal to this approach, because we can use whatever out there.
Exactly.
The other thing is that this approach isn't tied to a specific swab. Some of the FDA approved ones that are all packaged are tied to a specific swab, and you can't switch those out. So this is more generic. The rest of the material. Right, we're swab agnostic, and all of this, the material that you need to run it are all bulk reagents, right. And so they come into play because you're hand pipetting, so you don't need specialized plastics, you don't need specialized reagents, and that's one of the beauties. That's why I think I'll just throw it out there, but besides helping with COVID, this is actually a really robust approach that should be incorporated into a pandemic response. I think the idea that you can break out a set of instruments and quickly scale something is not going to go away.
Right? This should be in the tool bag, because there will be more pandemics. Right. So it will be some other, earth-threatening.
And like John said, this is all set up vendor agnostic. Right. So there's a number of qPCR machines. There's a number of thermocyclers. There's ones that we use specifically. But for extraction, we're not worried about having the reagent for that, because we can get it in bulk. Same thing with the reagents. Like John mentioned, the swabs become really kind of the gating factor. But we can use a number of different swabs that are out there, and we know that everyone's ramping that. So we really expect that to be the way to go. Right. And just to circumvent, there's been a lot of news about, they can do a saliva test. Of all the saliva tests they've talked about, there's been one that they actually got results on, and that needed the copies of the virus it needs for that to work were really high. So we don't think that's a viable solution right now.
Sure. So if we get this thing blown up, I can tell you firsthand that a lot of doctors' offices right now are working purely on a telemedicine basis with their patients. And so if this thing blows up and you've got 500 at one site getting processed every day, it really leads to the next question of IT infrastructure, patient registration, database management, how you get them that data connected to their healthcare provider. So what is involved in getting this set up?
I'll answer it first, and then John can cover because he has a lot more experience in these discussions. But one of the main reasons we're looking at moving the machines directly to the medical centers is they already have the accession in place because it'll be mostly their own patients coming to the centers. It's when you start going on a much broader scale that you're testing out in the field that's not connected directly to the hospital system, that becomes more the IT issue. And there's a group that's working with us right now. It's called Tilda, that focuses specifically on IT solutions. So they're addressing this directly. That's really a big part of what they're doing with the clinical trials. So their expertise, when we looked at who could really kind of embrace this, since clinical trials work outside of the EMR and then, and they tend to be very tightly run, we thought they'd be a perfect group, and they've got great ideas for running this. John, you want to add anything to that?
No, that's true. Tilda is providing the infrastructure in a cloud-based system, and as John Power said, the idea is how do you connect those? There's some robust standards that are out there, and because this is a single approach with a single system, we've standardized all the variables because we're not trying to make something unique as much as we're trying to make something ubiquitous. So there's a way of making health systems that's part of the infrastructure that's come out from some of our national programs and such. That's quite robust. Tilda's been using that, and we'll have a server set up so that it can report those back, and it will report those back in the same way. And so you have what it'll look like from the health system is I collected a sample that went to an instrument, and what came back is a result of that sample from the instrument. And again, right, as we go over their requests and things slow down, the ability to dismantle this infrastructure is also an advantage.
Right.
It's not only that you have to bring it up, by bringing it up by non-specialized instruments, doing a focused test means that you can also dismantle it. It's the equivalent of a temporary facility. And I think that's an advantage also, is that as we get, as we have less of a need for population level testing, it can be shrunk down.
Yeah,
right.
and it gives that flexibility. Yeah, because it's, in some cases you look at it and not knowing enough about COVID to know, well, can you get it again? You've got the flexibility to leave it in place, take it down, expand it. But that's really, when you look at it, it really fits whatever application you want. You got flexibility, and that's what's really beautiful about it. And it's, Tilda, like the rest of us, are all volunteers. So there's not the people doing this don't have a separate agenda. You just want to get this fixed and get everyone
doing it for the right reason. So does this testing meet the FDA guidelines, and is it approved for COVID-19?
It is using, so the FDA, essentially the protocol for approving it, this fall under the lab developed test protocol.
Yeah.
And the FDA, under the emergency declarations, has given states a lot of leeway about how they define that and pay attention to it. The volunteers beside myself, there's another very important volunteer, Monica DeBaca, and we're both pathologists. And so in designing the protocol, we designed it and worked on it so that we feel very comfortable it would pass all the regulatory involvement in relation to developing an LDT and assuring its performance and such. So the answer is it follows the regulatory environment and can be used, and we're quite confident of it.
Great.
But it doesn't have a 510K
Right.
approval, and we're
Right.
not trying to provide that.
Sure. So what I want to do is I want to share this beautiful website you guys put together called Rule Out COVID-19. Nice work on putting this together. So my next question is, are you guys looking for any funding to get this up and running? I mean, you guys are doing it altruistically at some level, but it does cost money, it does take time and energy. So you have this incredible website as a call to action, ruleout.org. So what would you say, are you looking for funding, or what are you looking for to help really blow this out?
Yeah, right now, if we had funding, we could accelerate some of the work we're doing with local hospitals. We're talking specifically to 4 medical centers in Southern California, 2 out in the Inland Empire and 2 in Orange County. And the funding really comes down to a case by case on centers that would like to deploy this, because they're the ones that are going to need the funding. So that becomes really the how do you allocate the funding? But yeah, there is a funding need that we're trying to address.
Okay, super. So obviously I showed the website. Is there anything else we'd want to share with the audience that we haven't discussed?
No, I think the thing that really stands out to me is this is not a unique solution where you've got to pick a vendor and you got to get unique equipment, you got to go train separately. This is the broadest based, most, when I look at from a credibility standpoint, it's the most time-tested technique for doing viral testing. It's easy to deploy, and we really need to get the leverage behind it both politically and nationally, because there's centers, I didn't mention we are working with some centers in Iowa as well, because as people hear about this, as long as someone's got the motivation and they know that they can get a PCR unit, which a lot of them already have, it's very easy to deploy. We just got to get awareness. And with all the noise out there, we're a small group, we're all volunteers. We're not making any splash. You don't see us in the Times or anywhere else. But every time I hear, Como talking about their problems in New York, it's like, this would have been a perfect thing to put into Central Park.
Right. At a fraction of the cost.
It's exactly what we're talking about.
Fraction of the cost.
Yeah.
And the whole goal is if we can get, the way to get back to work is people have to have a feeling of safety in their interactions.
Yeah.
And whether the government says that we can move around, until you feel more confident about moving around, we're gonna self-isolate.
Yeah.
Right.
So let's help all of us as best we can.
From the political standpoint, I bring up New York specifically, and it's not, when I look at all the efforts Como's doing, I'm real impressed because he's very proactive. This is one that if he knew about what we were doing, I think it would have been his first choice. It's just, we don't have the access to get in front of him. But this is one where the way I always look at a solution is, when you talk to the experts, can they say there's a better way that doesn't have a separate agenda? And I really have not found a better way to do this than what we're proposing. I think it's the best solution, and it provides a fast solution. It's the only way to really go out and sample on a large scale. Like John talks about, when you do multiple testing, this is the only way. You've got to check that volume way up.
Right.
Yeah.
So, I think cutting through the din and the noise and the sound and the echo chamber, if you're in front of President Trump and the coronavirus task force, you got 30 seconds to make an elevator pitch. What would it be?
I would say,
yeah, you go first, John.
Well, you go first, John.
All right.
I'll go second.
And what I would encourage you guys is keep it high level for the layperson out there. That's not
No, but she's 30 seconds. It's like, look, we have a method with existing equipment to treat over 7 million people a day, to test over 7 million people a day. That's all I need. 10 seconds.
Exclamation point. That was good.
Yeah.
John Spinoza, how about you?
I would say the same thing, that we have the equipment's there and the processes there to evaluate 7 million people a day in less than 24 hours. That's the other thing, is that the turnaround time is pertinent to the real need.
And John,
what's
that's the elevator
impressive
pitch.
about that 7 million is President Trump's all about numbers, right? When he's up there, he's always talking about we're the greatest, we're the best. 7 million a day would just blow it out. We got 350 million people in this country. 7 million a day.
and that's a conservative number.
That's incredible.
We did I think I just saw today that they touted that they did 250,000 tests yesterday nationally.
Right. Right.
You know,
We got to level up, guys. Level up.
Yep.
And like I said, Ben, that 7 million is conservative.
Right. Good. John and John, I really appreciate
Great.
your time today and beyond. It was a very a good in-depth conversation, needed to get out there. And really appreciated your insight and your expertise.
No,
Thank you very much for having us.
Absolutely. Until next time.
Thanks, Ben.
Thank you.
Thanks, guys.